No, but they should. Okay, now it's on. People, please get in. We are ready for our next plenary, bit awkwardly numbered plenary 1. And those of you, and most were here in the opening plenary, know that we are still missing the last of our 3 speeches from the opening plenary. And it's now really my pleasure to welcome the regional director of the WHO region for Europe, Hans Kluge, who is now with us. I think I don't need a big introduction. Hans, as you know, is from Belgium, and he probably took over as regional director at the most unlucky, or you could say challenging time in February 2020. So your term is basically the same as the pandemic's term so far. Hans, we are really looking forward to your speech to us. You have the floor.
Thank you very much, dear Reinhard, dear President Nagieva, dear future President, my good friend Tit, dear Professor Martin McKee, and so many friends. I have to apologize, I came a little bit later. You know, it's good to meet face to face, but you're reminded also about the flight challenges. But one of my public health mentors, Professor Jose Maria Martin Moreno, used to say, intelligence is the capacity to adapt. So I must say there are a lot of intelligent people here in the room. Dear friends, it would be an understatement to say that much has happened since we all met physically in Marseille in 2019, when Professor Natasha Azzopardi Muscat was the UEFA president. It seems like a very, very long time ago. But let me begin by saluting you all, everyone gathered here, the many old friends, and I'm amazed so many young public health professionals. The entire public health workforce and the frontline workers who have made huge personal sacrifices over the past 2.5 years. The COVID-19 pandemic has been a watershed moment in the history of public health on our continent. Governments and public health authorities have had to make difficult choices and to take bold actions to save people's lives and protect the vulnerable in times of uncertainty. But I believe that we acted fast and we acted firmly. And because of your courage and wisdom and your unflinching commitment to follow the science, we did save many lives. The ripple effects of the pandemic, however, will be felt for decades. Consider, we now face an unprecedented mental health crisis that is affecting at least 1 in 6 people in Europe and costing EU governments at least 600 billion euros a year. Last week in Greece, we listened to young people who spoke about their lived experience with mental health issues made worse by the pandemic and its aftermath. Responding to this public health challenge and others, not least long COVID, it will require concerted action from the highest political levels to the grassroots of society. And yet, strengthening our health systems in response to the pandemic is not the only challenge we must address. A devastating war, now in its 9th month, continues to cause immeasurable suffering in Ukraine and across Europe. To date, there have been over 660 attacks on health facilities and healthcare staff verified by WHO. This war makes the coming winter one of the most challenging in recent times for all of us. In the coming days, I myself will go for the 4th time this year to Ukraine, to the front line, to stand by people and health workers in the face of what will be a harsh winter, to advocate and engage support for people's physical and mental health needs, particularly in the newly liberated areas. Throughout the region, the energy and cost of living crisis means that thousands of families will need to choose between paying for energy or other necessities, between staying warm and getting healthcare. And today, this energy crisis is being compounded by a global climate crisis that impacts public health and public health services and demands urgent action now. As we gather here in Berlin to discuss the future of health systems and public health, world leaders are also discussing how to save our planet for the sake of our children and grandchildren. And all these challenges go hand in hand. Dear colleagues, friends, I know I may risk sounding a little too alarmist, particularly knowing that I'm a born optimist. But we have to accept the reality that we are living in constant crisis mode, in circumstances that are eroding the health gains made through the painstaking work of many of you in this room and those who led the path before us. And if we truly want to recover and get back to improving the health and well-being of our populations, we need to move to a new paradigm in public health, to what I call a dual-track approach. This means that on one hand, we must invest significantly in preparing for mounting and often overlapping emergencies. In this regard, our work in setting up a pan-European network for disease control is an important advance. And on the other hand, we must ensure that we redouble our efforts to prevent illness, promote health, and strengthen day-to-day essential health services. At WHO, we are firmly focused on this dual-track approach, and we have started taking concrete action. Just yesterday here in Berlin, we convened a meeting of the NCD Advisory Council on Innovation for Non-Communicable Diseases and are gathering the best developments to tackle and reduce the burden of NCDs. And my sincere appreciation to you, dear Iveta, for your support, to Ilona, and you, dear Martin. Next year, we will host a global primary healthcare conference in Kazakhstan, which will mark the 45th anniversary of the Alma-Ata Declaration. A firm commitment from governments to ensure that everyone, everywhere, is able to enjoy the highest attainable standard of health. I am very glad to see that the Berlin Statement, which WHO Europe strongly endorses, includes clear actions to advance this dual-track approach. It does so firstly by recognizing that health systems need to be resilient and robust in order to respond to emergencies and maintain essential health services. Secondly, by committing to reach beyond the health sector and work with economic, social and political partners to strengthen public health systems and improve people's health. The Pan-European Commission on Health and Sustainable Development, which was chaired by Professor Mario Monti, reached a similar conclusion. And I really must thank the former UFA president and my very dear friend and colleague, Professor Martin McKee, for leading the scientific evidence that informed the Commission's final report. This work will be taken forward as we prepare now for the high-level forum on health in the well-being economy to be held the 1st and the 2nd March 2023. Thirdly, the Berlin Statement acknowledges the key role played by science and innovation in public health and the need to commit to more and better investment in research and development. And it is on this last point in particular that the public health workforce, all of you, come in. Prior to the pandemic, public health professionals struggled to attain visibility for their work. But the focus now placed on public health has prompted health systems and governments to reflect on how we can attract, retain, and nurture the public health workforce. In moments like today, seeing all of you gathered here with so much enthusiasm, committed and determined to make a difference, I am really filled with hope and optimism that the future for public health in Europe is bright. But we also need to acknowledge that it is time to hone our leadership skills and invest in public health leaders of the future. With this goal in mind, WHO Europe and the Istituto Superiore di Sanità are right now, for the first time, delivering a public health leadership program in Italy for public health professionals like yourself. As a final reflection, allow me to quote Rudolf Virchow, who worked here in Berlin many decades ago and who firmly believed that die Ärzte sind die natürlichen Anwälte der Armen und die soziale Frage fällt zu einem erlebigen Teil in ihre Jurisdiktion. Physicians are the natural attorneys of the poor, and the social problems should largely be solved by them. My friends, this European Public Health Conference embodies the vision of delivering health for all through the power of partnership. There is great strength in the collaboration we represent. Although the challenges we face are daunting, we face them together, and we will overcome them together. Thank you for your dedication and determination.
Yes, thank you, Hans, for these, I would say, they're not only inspiring because they also make us think, and it is a bit daunting, but we are here to address these challenges. And the first challenge is addressed in the next plenary. I hand over to you, Natasha.
Much, Reinhard, and thank you very much, Hans, really for making such an effort to be with us here today. We are truly, truly grateful. And I think the note on which you ended your keynote is the natural bridge to our first plenary today, which is really seeking to ask the question, can people afford to pay for healthcare, and to bring the latest evidence on inequity on financial protection in Europe. And I would like to invite our keynote and panelists for this first plenary session to make themselves comfortable in order to kick off. And of course, as you all know, universal health coverage is the first pillar of our work within WHO and the general program of work. And sometimes people wonder perhaps, but is this still an issue in the European region? Is it an issue in the European Union? And as you will see over the course of the next 45 minutes or so, in fact, there is still quite a lot of work to be done because we still have gaps in this area. And in this session, we are going to highlight the most prevalent gaps, the policies that cause them, but more importantly, what countries can do to close them. And can we please first have the video of Lisa? Who is Lisa? Lisa is anyone who we might know. Could be a mother, an aunt, living anywhere. There are people like Lisa in all European countries. And just watch Lisa as she faces this dilemma. Does she pay her electricity bill or does she get her prescription medicine? Let's see. Right, so how many Lisas do we have across the European Union? And we'd like to involve you over here and bring up our Slido question and ask you to think about what percentage of households face catastrophic out-of-pocket payment spending on health. To make it perhaps a bit easier, we are asking you to focus on EU countries, given that we do have a very, very wide variation across the region. And you are able to choose between the three options: less than 12%, between 1 and 9%, between 1 and 19%, and of course I will highlight that option A also includes 0%. So please take out your phones and pick the option, and let's see what you choose. Just in case anyone is wondering what we mean by catastrophic spending, it's basically the decision that Lisa has had to make when a household has to spend such a large share of their budget on out-of-pocket payments for health that they cannot meet other basic needs. So let's give you a minute or so, and then we'll start to see the results as they come up. And thank you, Emilia, for facilitating and supporting our session. Okay, so I think that we have here a very smart audience. Sarah, no? Don't you think? That is the correct answer. What does it mean? It means that no single country across the EU can boast that it has achieved 0%. It also means that there is a very wide dispersion. But let's move quickly now to our first keynote presentation to get a better perspective on the state of play and the evidence. And it is my pleasure to introduce our keynote speaker, Professor Charles Norman, who is a Professor of Health Policy and Management Emeritus at Trinity College in Dublin, Ireland, but also a Professor of the Economics of Palliative Care and Rehabilitation at the Cicely Saunders Institute at King's College. And I think for many of you, like myself in this room, Charles has been one of our teachers and mentors as we undertook our training many years or a few years ago. So Charles, over to you, and thank you for joining us.
Natasha, and I'm very proud to have been asked to speak on behalf of my colleagues and friends in the Barcelona office who have done sterling work to bring together really important information and understanding about the ways in which financial hardship is related to people's need to access healthcare. I'm always tempted with a question like this to give a yes or no answer. If you ask a question, can people afford it? The answer is a lot of them can't. And whereas universal health coverage aims to remove barriers to access and to prevent catastrophic spending, we have good evidence that there is serious catastrophic spending in many countries, as shown by the results that we saw from the votes that people have taken there. There's serious catastrophic spending, and there's also strong evidence that many, particularly poorer people, are deterred from using services by the presence of user fees. So we have this twin effect, and it's the theme I'd like to make sure that we get into our discussions today, got the twin effects of the visible catastrophic spending problems that people face and the invisible problem of people being deterred from using useful services with unfortunate long-term consequences. We have newer and better understanding than we had of these patterns, and I think the strength of the new evidence comes from the fact it is both across many countries and across many years. That means we now know with great certainty that these effects are there, they're real, and they're strong. But we know that the poorest are most likely to face problems of catastrophic spending, and mostly this is in the areas of buying medicines and paying for dental care. And I want to give a little bit of particular emphasis to dental care because in most countries, dental care is the pure relation of other areas of healthcare. This should not be the case. There is very good evidence about the importance of oral health, both for its direct effects on people's ability to have good nutrition and other good healthy lifestyles, but also because good oral health is associated with preventing many other diseases and other illnesses. Similarly, I have never understood the idea that people should not have to pay to find out what their problem is, but they should have to pay to solve it. So we give people good access to primary care and hospital care, but as soon as they need to find drugs, many countries charge significantly for them. This, to me, makes no sense, and I'll talk about that very briefly a little bit later on. We know that user fees, in general, are bad for equity, they're bad for incentives, but the good news is we can make them less bad by improving the design, and that will be one of the other themes we have today. Now, what does the evidence look like? Well, countries that have better financial protection, those on the left of the diagram you're seeing now, in general, financial protection is stronger and catastrophic spending is less. Countries with weaker financial protection have much higher levels of catastrophic spending. You can see that most of the catastrophic spending is amongst poorer people, but for various reasons, there are some countries that have relatively lower proportion of the catastrophic spending in poorer people and more in people on middle incomes. And this is due to the particular design of the user fees that are charged. But overall, the picture is very stark. You can prevent catastrophic spending if you have well-designed healthcare financing. The other theme that I was encouraging you to think about is the effects on unmet need. And here I think we have a very simple description of the problem. Catastrophic spending is very much concentrated in the poorest parts of the population. It's very much concentrated around medicines and dental care and those areas. But you can see from those dots, what those dots are showing is that unmet need is the other side of that coin. Catastrophic spending is there, but it is there despite the fact there are large levels of unmet need in the system as well. And you can see that there's a reverse correlation. The more catastrophic spending you have, the more unmet need you will also see in that population. It is not complicated. High levels of user fees lead to both deterrence of useful services as well as catastrophic spending. And I want just very briefly to make the point, it shouldn't need to be made, but it has to be made. There is no evidence that user fees are useful for discriminating between useful and pointless use of services. There is no evidence. If I can just repeat that, there is no evidence that suggests that user fees are useful. And I want us to focus very much on how can we make them less harmful and how can we make them less. We can see here that stronger financial protection, particularly where there is well-designed user fees, can reduce their harmful effects. And you can see on the left-hand side, we have better protection mechanisms where there are co-payments, they're low and fixed. On the right-hand side, we have co-payments which are often proportions and percentages. So there's a very simple point here. It is much better to have user fees that are controlled and contained down to very low levels. If you have high levels of user fee, you will get high levels of catastrophic spending and high levels of people being deterred from using useful services. So we can do better, and we'll be talking about this later, but we can do better by having the user fees designed in such a way that they don't particularly penalize people on low incomes who cannot afford it. So what's the way forward? The way forward is the evidence shows that financial protection works. If you have very low financial barriers to accessing care, people will use useful services and they will not face catastrophic spending. It does work. The effects are a little bit complex. We need to understand the countries one by one. Every country has slightly different problems, slightly different patterns, but we see the same overall picture everywhere: high fees, high levels of deterrence, and high levels of catastrophic spending. The myths about user fees are myths. Myths are things that are not true. And if something's not true, we shouldn't allow people to say things about it because it's not true. I don't want to invoke any thoughts about any former US presidents, but things that are not true, and we shouldn't allow them into the system. But we can design better user fees. If we can't get rid of them altogether, we can design better versions of them. But it's better to be working towards their abolition altogether because they do no useful job and they cause significant harm. And if any of you after lunch have been listening, thank you for your attention.
Thank you very much, Charles, and I'm sure many were listening, and at least I feel heartened by the fact that we've created probably a huge amplification effect of your message from the audience we have in this room. And I think your message was very clear. I would just like to remind people that although it's a huge hall and we can't sort of take questions from the floor in the limited amount of time, technology does help us overcome this, and Slido is the place where you can let us have your questions, which we might be able to have some time for the panelists to see coming up on screen and think about as they prepare their interventions, as well as any reflections and comments on anything that you have heard from Charles or that you will hear from our panelists. This also will help our colleagues in the Barcelona Office on Health Systems Financing as they take their work forward, as they seek to understand perhaps where are the areas where people really want to see more research, want to learn more. And it's my pleasure to introduce an excellent panel, starting with Sarah Thomson, who is our Senior Health Financing Specialist in Barcelona, but actually really the person behind all these financial protection reports that are being produced. Professor Reinhard Busse, who I think needs no introduction after his excellent also presentation this morning. But of course, Reinhard is also very much working with us in his capacity as the professor at Technische University of Berlin and as one of the authors of the German Financial Protection Report. Kaisa Immonen, who is the Director for Health Policy of the European Patients Forum, because we really need to keep listening to civil society to make sure that we are doing what is absolutely necessary. And my colleague Tamás Evetovits, who heads the Barcelona office and who has really been responsible for pulling this plenary together. So, Sarah, can I please start with you? And we've just heard Charles repeating and reiterating this message. And in spite of a lot of consistent research evidence showing the limitations, Charles said the harm of user charges, all European health systems still have them and use them. Does the research evidence show any sign of progress in protecting people more from the adverse effects? You've been doing this work now over a period of years. What are your reflections and views?
Thank you, Natasha. Well, I'm going to suggest 3 reasons why I think countries are still so wedded to user charges. The first one is belief. Some countries probably still think that user charges are a useful policy instrument. Not everybody got Charles's memo, it seems. And outpatient medicines really suffer from this, because almost every country in Europe, this is the one thing that almost every country in Europe makes people pay for at the point of use, prescribed medicines. And what this suggests to me is that health systems don't really trust their doctors to be prescribing properly. In response to this problem, what we can do is to show policymakers that if they genuinely have concerns about inappropriate use of medicines or inappropriate prescribing, then they really need to be focusing on what doctors and pharmacists are doing instead of penalizing patients through user charges. The second reason is money. Even though user charges don't really don't generate a lot of revenue for health systems, it can be really difficult to give up even a relatively small share of your budget, especially when times are difficult, when your government is facing financial pressure. And I think in response to this, what we can do is to support countries to make the case for greater public investment in health systems. And a third reason might be inertia. This idea that this is how we have always done things. We had user charges yesterday, and we're going to have user charges tomorrow. And this, I think, is where the work that we have done can be really helpful to countries, because we have identified the key things that countries can do in order to make user charges much less damaging for people. And we are also systematically documenting information about policy changes that countries have introduced to increase coverage and to reduce user charges over time. So what we find is that actually there has been quite a lot of progress in the last 2 decades. In the years since 2000, there has been significant expansion of coverage and significant efforts to reduce user charges in some countries. Some countries have followed Charles' advice very carefully and abolished user charges. So countries like Scotland, Northern Ireland, Wales, and the United Kingdom for medicines, countries like Germany and now Ireland for primary care visits. But many more countries have actually tried to improve the design of their user charges policy, to improve the protection from user charges by exempting low-income households from user charges in Latvia, in Lithuania, in Spain, by introducing or strengthening income-related caps on co-payments so that nobody has to pay more than a certain share of their income. Changes in Austria, Belgium, Cyprus, the Czech Republic, Spain. And importantly, countries are beginning to recognize and address the administrative barriers that prevent people from benefiting from the protections that are actually already available. And we see examples of this in Estonia, in Finland, and in Sweden. So I think change really is possible. Having said that, we saw a blip during the economic crisis that followed the global financial crisis in 2008, when countries, particularly countries that were really hit hard by the crisis, did limit coverage and did, in many cases, increase user charges. And as a result of that, many of those countries did actually see an increase in catastrophic spending in their health systems. And this is something that we've recently documented in an article in the journal Health Policy. But even in crisis, some countries were actually able to protect the poorest households from user charges. Several countries were able to reverse the damaging policies that they introduced in the years that followed the crisis. And following on from that, responses to the pandemic show, I think, that some lessons were learned, because when the pandemic struck, countries moved really quickly to waive user charges for COVID-related treatment. So all of this, I think, Natasha, shows that progress really is possible when countries know what to do, when they have a laser-like focus on protecting the poorest households, and when they're prepared to act quickly. And I think all of this is really very much needed right now in anticipation of a very difficult winter to come for many people.
Thank you very much, Sarah, for really giving us concrete evidence and examples from many countries, for also drawing our attention to the fact that we have to be on our guard that this very difficult time and crisis does not lead to knee-jerk reactions, and showing that it is indeed possible for the right policies to be instituted even in difficult times. I come to you now, Reinhard. You are, I like to say, or I like to hear you say, or you like to say that you are the brain behind the famous cube, the UHC cube, with these 3 different dimensions, and we'd like to fill the cube up entirely, and in many countries, however, the cube is far from full. So the dimensions on the cube, the population coverage, the service coverage, the cost coverage. Where do you see that the greatest challenge seems to lie? And maybe you can tell us how useful this cube still is today in this current crisis in helping us to think through the challenge and give the right policy advice?
Well, maybe I go briefly to the time when I invented it, about a bit over 15 years ago. The World Bank at that time had asked me to write a report what low and middle income countries can learn from high income countries, because often the low and middle income countries, which we also have within the European region, say, you know, we cannot really adopt anything because we are lacking the money. And I was saying, well, first of all, even today's high income countries were at some stage low and middle income countries. And then I thought of the principles when the NHS in the UK was developed: universal, comprehensive, free at the point of service. And me being a non-native speaker, I thought, what is the difference between universal and comprehensive? Sounds pretty similar. And then I came up with this cube, and I said, okay, that people spend money out of pocket is not only user charges on certain things which are covered, but there are three reasons. The one thing is people are not covered at all, so they are uninsured. The second question is, are the services which they utilize included in the benefit package? And we saw here from the European countries, the dental care is often the problem, not the user fees, the cost sharing, but that it is excluded. And the third dimension is for people who are insured, the service is covered, but that there is formal cost sharing, that you have to pay a certain percentage yourself. And then I visualize that in what's been picked up by WHO. And clearly, I mean, and it should be in this order, I think. I mean, the first thing is, if people are not covered at all, they are faced by the entirety of potential expenditure or of unmet need. And so the first thing is, and that should be, that's why I think the universal coverage is named after the first dimension. Universal, everybody should be covered. The second dimension, in Germany, I should say, I mean, we were the first country to introduce a social health insurance system, but it took us from 1883, when it was introduced, 125 years till 2009 before we tackled the first dimension, which I would not recommend any other country to take such a long time. We did much more emphasis on the second dimension, so the service coverage. We have a very generous benefit package, maybe too generous. So if I were advising policymakers, I say, before you waste on certain inappropriate services, before you put those into the benefit package, first see that the population is covered, and make sure that the third dimension, so those necessary services for everybody, that people don't face cost sharing. And Germany did it the other way around. So we started with the cost sharing. We saw in the slides presented, Germany was on the left-hand side, because we have a generous benefit basket, non-prescription drugs for children, for example. We have caps in cost sharing. But if I would advise any government, really start with the population coverage, then have good health technology assessment to decide on the service coverage. And then once you have necessary services covered, then keep the third dimension as small as possible.
Excellent, very good, Reinhard. Very clear message, very helpful to us. And good to know that in the countries we are working with and advising, we are really echoing, I think, what you have just told us here. First, cover everyone to some extent at least, then start to increase the services and keep your eye on the ball and try to balance also the user charges, out-of-pocket payments, keeping them to a minimum as far as possible. Very clear message. Thank you very much. I come now to Kaisa. And Kaisa, you have been very involved in developing a survey, a patient survey, hearing really from patients. And the European Patients Forum is, of course, a very strong advocate for reducing access barriers to patients. And in your survey that you have conducted on access to healthcare, I mean, already from the presentation that Charles gave us, we could see that there were some areas that seemed to be more important than others when we come to unmet need and catastrophic expenditure. So from the results from your surveys, what are the areas where patients really are facing this unmet need or this access barrier, and who is the most vulnerable? Who are our Lisas?
Thank you, Natasha, for the question, and thank you for the invitation. I remember having the first discussion a few years ago in Gastein when the first evidence was presented by WHO, and it's good to continue. The evidence is not good, but it's good that it's out there, and it's a very useful tool for us in the civil society space. Before I say something about our survey, I want to explain why people with chronic conditions, which is the community that I represent here, are generally vulnerable to financial precarity as a result of being ill. It's true that poorer people tend to be sicker, but also having one or more chronic conditions makes people more vulnerable to poverty. Because the impact of having a chronic illness is multiple and it's accumulative. The impacts are physical, but also mental, emotional, social, and financial. People rely on continuing access to healthcare and other related support services over a period of time. Not only treatment, but also perhaps rehabilitation and medical devices and home adjustments, things like that. And delays in accessing services that one needs will lead to disease progression in many cases, for more invasive treatment, more expensive treatment, having to access various benefits, but also possibly inability to work, which is also another factor then that increases the risk of poverty and reliance on social benefits. And I want to just point out this cumulative thing of out-of-pocket costs, because this is very well shown in the WHO evidence, but we feel that sometimes policymakers don't really see the whole picture, where little things add up to people's experience. So not only co-payments of medicines, for example, or treatments, but also the costs of medical appointments, which can be many, travels, products, cost of time off, or loss of income. So just as an example, a patient study was done in Finland by several patient organizations in rheumatoid arthritis, asthma, psoriasis, and IBD, inflammatory bowel disease, in 2018, so this was before the pandemic, and they found that 1 in 4 patients had postponed buying medicines prescribed to them. 1 in 10 had not bought a prescribed medicine because of the cost. 1 in 5 had foregone other expenses, such as food, because of healthcare fees, and 1 in 10 had not sought a health or social service because of fees. And this last point comes to your presentation and the invisible group of people who do not spend out of pocket, possibly because of such factors. So this is a wealthy country, Finland. This was before the pandemic, and it doesn't even capture the most vulnerable in society. I'm very well aware that my community does not represent everyone, and we do not represent the poorest, but even in our community, we have these issues. So we did a survey in 2016, and it will be repeated next year, which wasn't really about financial impact per se, but since affordability is one factor in our definition of access, we did ask a question. And 22% of people who responded to our survey said they regularly experience financial difficulties as a result of spending on healthcare. Almost 40% said sometimes, and only 18% said never. We also asked if they felt their healthcare costs were adequately covered by the healthcare system, no matter how organized. And about half said yes, agreed or agreed strongly, but almost a third disagreed and said no. So this is also in line with the evidence from your research. And we think it's time to repeat our survey, and we're going to do it in the next year to see if anything has changed. But we will also adjust the survey a little bit, and we will look at the findings of WHO research. We might, for example, introduce a question about not seeking a healthcare service because of cost, Or we might ask also how easy it is to navigate the system to get the benefits that you are entitled to. So this is the next step in our journey. Thank you.
Thank you very much, Kaisa, for sharing the findings. And of course, we eagerly await the next round now of the survey to understand, since the COVID pandemic, the other crisis that we are facing at the moment, particularly also around energy, what is this meaning now for patients in the European region? And thank you also for saying that you are finding it useful to draw on the research and the findings that we are producing on financial protection. So, Tamás, it's been a long journey. You've been around a bit, as I have too, and we can look back where we started. And maybe the starting point was the Tallinn conference in 2008, when we were talking about values and principles. And UHC at the time was clearly, and financial protection at this level of objectives, targets, principles. And today we are seeing that it is still, for some countries, a principle and objective that we need to work towards achieving. 10 years later, 2018, you published the first comprehensive financial protection report. Of course, there was an evolution of thinking and a journey. Where are we going to be also now looking forward in 2028? What remains next to be done? What are your plans for what still needs to be done? And how can this community of experts also help us?
Thank you, Natasha. So I think it was really helpful, Reinhard, that you explained this otherwise not so easy concept of having 3 dimensions of the UHC cube. So along these lines of playing around 3, I would like to offer 3 ingredients for success in order to make progress. One is the political commitment that Natasha mentioned. That first real, very strong commitment was in Tallinn, in the Tallinn Charter. It is unacceptable that people become poor as a result of ill health, as it is stated in the Tallinn Charter. The second is the need for evidence to inform policy. And the third is acting upon the evidence. And although political commitment on its own is quite hard to get, especially with 53 member states, but still, in this order of political commitment, having evidence, and acting upon the evidence, I think it's an increasingly difficult task to get there. Now, over time, what we observed, of course, is that at the time of the Tallinn Charter, everybody celebrated this statement that no one should become poor as a result of ill health. No one had an idea how many people are affected. The evidence was just still not there. It was not there in a form that is systematically collected and monitored and compared across countries and over time. But, you know, we sometimes feel very comfortable to make commitments without knowing the evidence. And also, as we all know, policymakers feel very comfortable with evidence-free policy making. But they are very keen to ignore the evidence. And we didn't have them. So we first had to produce it. And I think that was the very important stage of the past 10 years, and that's why it took so long to get to the point that in 2018 we published the first report that captured 24 countries of the European region using the same approach, and not just producing evidence, but relevant evidence, relevant for policymakers. So in addition to showing numbers that we have seen in Charles's presentation, the real value added in this work is to look into the detailed country-specific and context-specific analysis. What is driving financial hardship? Who are the people? Who are the listers? And how can we make a difference? And that's where we get to the third point. How can we act upon the evidence? And over time, I think that's where we are now at this stage, that we really need to join forces. It's just not enough to present the evidence to policymakers. It's just not enough to show that they themselves committed to making progress towards UHC. We have to join forces and push them. And this is exactly why we are very happy that by now the European Commission, the EU reports are using the evidence generated from the Barcelona office. OECD is using this evidence in their annual publications. And next year, hopefully in June, in Barcelona, we are bringing together all these partners in a forum, in a first forum on financial protection in Europe, where we hope to show you not just evidence from 24 countries, but evidence from 40 countries. And in addition to the numbers, evidence on the stories, the story behind the numbers, because for the same number, there may be a very different story depending on the context.
Thank you very much, Tamás, and all our panelists. And thank you to all of you who are being very active on Slido. I'm in contact with Emilia, so I know more or less what is happening. Some very interesting questions. We have 10 minutes left. I will ask you to keep your answers short. Tamás, this is something that you and I have thought about a bit. So I'm going to ask you to try and explain very briefly. But there is a question around the role for pharmaceutical companies to reduce medicines costs, to reduce financial hardship. I'd like you to touch upon very briefly the link you make so beautifully around the novel high-cost medicines and financial hardship and out-of-pocket payments in 2 minutes.
So as Charles said, there are some myths, and the interesting feature of those that those are myths. So we shouldn't debate that. And one myth is that it's the high-cost treatment, the high-cost medicine that drives financial hardship. That's a myth. It may be true for some individuals, but when we look at the population level, the main driver of financial hardship, as we have seen, are medicines, and normally medicines that are actually not very high cost. Why is that? Normally, when something is very high cost, that's the policymakers' thinking is that we have to provide insurance. What is it? Insurance covering the cost. So if it's high cost, if it's a cancer medicine, it's usually fully covered. What's not covered is the very cost-effective, sometimes very low-cost medicines, especially for people with several chronic conditions, and over time it accumulates. So what Natasha is asking me to do is to make the link. Okay, but how does the two challenges link together, that we want to cover high-cost medicines or high-cost technology, but at the same time what we observe is that the way we deal with it is what Charles alluded to, these implicit rationing, that, okay, we need to add something to the benefit package, which is new, novel, sometimes not so novel, but very expensive. And what happens is that with percentage co-payments, there is always this relatively easy instrument at the hand of the policymakers to reduce the cost coverage for some other services and medicines and increase the out-of-pocket expenditure, not on the high-cost medicine, but on the frequently used, relatively lower-cost medicines. So by shifting the burden to patients, and that's why we need to carefully manage how high-cost new technology, high-cost new medicines carve out a large share of the budget that is available for medicines. Hard choices are there, and we will never escape from those hard choices.
Thank you, Tamás. Thank you. Kaisa, can I come with a question to you? So people have asked about persons with disabilities. Do we have data that they are actually now amongst the populations to be more exposed? And another question, mental health. Do you have any data on mental health from your survey?
Yes, well, the short answer is no, because my organization is separate from, let's say, there is another European organization working on disabilities, and we are the Patients Forum, and we have an understanding between ourselves that we don't cover each other's territories, although there is overlap, obviously. Many chronic diseases do involve some disability. So I couldn't tell you whether the European Disability Forum has made a similar survey, but I would imagine that people with disabilities would fall into the more vulnerable category for obvious reasons. Regarding mental health, again, because we do not work on a disease basis, we do not have answers on that, but we do work with several mental health patient and family organizations, so we can also consider introducing this aspect into the next edition of our survey.
Thank you. And another question which was highly voted. Charles, I'm going to put this one to you. Population aging. How can health systems afford to progress UHC without impacting younger generations?
Well, I think the first thing to say is that aging is not very important. You may be a little surprised to hear me say it. I'm only going on 71, so I think aging is very important for me, but it's not important for other people. But there is a myth that aging is a huge issue. Dying is the issue. People use high-cost services near the end of life. But what we know, which is interesting, is only very few people use high-cost services near the end of life. We know a little bit about them. They have multiple health conditions. We know they are badly managed. We know they get a lot of services that are not useful. And we know that quite a lot can be done to improve the trajectories of care so it can cost less and be better. So there are some wins there. I would just come back to Reinhard's point, because I always admire almost all points that Reinhard makes, that if we are looking at how we manage universal coverage, we have to have universal assessments, universal health technology assessment that allows us to make good choices. We will always have to make choices. We'll always have to make hard choices, but we really want to make good hard choices. And the end-of-life period is an area of that. Aging is a completely accommodatable problem. It's a slow, slight increase in costs over time. Some countries, like the one I live in Ireland, the big problem is we're dying in ever-increasing numbers because we didn't die early enough, so we're all going to die later. And there's a big tsunami of death coming, but not a tsunami of aging.
Thank you, Charles. I think that was a clear answer to a complex question. I'm going to ask Sarah a question, and Reinhard, leave you for the end, because I know you will be looking at me to close the session, so we do this together. So, Sarah, people are asking if you can explain a little bit more the link between unmet need and catastrophic spending and the differences and how you measure them.
Okay, so when we have out-of-pocket payments in health systems, for example, if you have user charges, some people will face a financial barrier to access. They will not actually be able to pay the user charge, and they will not be able to access that service. And those people will experience unmet need for healthcare. Some people, it could be the same people, but also other people, will be able to pay, well, they will find the money to pay for those services, but they will pay so much out of pocket in relation to their income, their capacity to pay, that they will experience catastrophic health spending or financial hardship. And some people will experience both of these outcomes. So we need to look at the two of them together, because a country could have a really low incidence of catastrophic spending, but that could be because so many people face financial barriers to accessing healthcare. They're not actually able to use the services and pay out of pocket. Or conversely, we might see a country that has reforms that massively increases access to healthcare. And we saw an example of this in Georgia, extended population coverage, but made people, so people had better access to services. They were covered, Reinhard's point, this was the first step, but because they didn't pay attention to the user charges, people had to pay out of pocket and experienced financial hardship. So unmet need decreased, but financial hardship went up. So it's very, very important always to look at the two things together. But in both instances, it's always the low-income households that are most likely to suffer both of these outcomes, and that's where the focus really needs to be.
Thank you, Sarah. And Sarah will be around, and I'm sure she'll be very happy to talk to anyone who has any more questions around this topic. Reinhard, we have an interesting question. If we abolish all user fees, where is that money going to come from?
I mean, the problem is, I think in all countries, and that I was stressing with the second dimension. So the first dimension is clear. Hopefully everybody is covered in those countries because only they have user charges. The second dimension is more problematic because in all countries we have, at least for certain people, that we utilize services inappropriately. And so if we abolish all user fees, we risk also that we as a society pay unnecessarily for these services. It relates a bit to Charles's remark that we don't trust the doctors. So we need to make sure that, and I would say we shouldn't abolish them, but if we keep user charges, we should tie them more to the appropriateness of them, but remove everything which is appropriate. And if these are appropriate services with a good cost-effectiveness ratio, even if people at first think they pay more, or no, that the system pays more and they have to pay more in contributions, it's worthwhile for society as a whole. I mean, that we have to think. If our health technology is good and we pay for services which are cost-effective, we should pay for them, whether it's tax-financed or social insurance contributions. So it's us all, but we get a good benefit ratio for them, so it's worthwhile.
So ultimately, it's about political decisions, and ultimately the public also affects political decisions. So maybe we need to start getting this discussion a bit beyond this room. But I think you'll be very pleased that we stuck to time. So I would just like to ask all of you to join me in giving a round of applause to Emilia, Charles, Tamás, Kaisa, Reinhard, and Sarah for this excellent session. Thank you for being with us. On time. Thank you.